Good afternoon, everybody. I'm Sally Warren, the Director of Policy here at the King's Fund, and I'm delighted to welcome you to our What's in Store for 2024 event, where we try and look into our crystal ball and answer as many of your questions as we possibly can in the next hour. So if you would like to ask any questions to us, please do so by using the box to the right of this video. And just to reiterate, this is very much an audience-led event. So you normally don't let us down as an audience. You normally ask us lots of very probing questions covering a whole range of topics. So I know we can expect some really good questions today, but please do pop those into that box to the right-hand side. Also to let you know, during the broadcast, we will be asking you a poll question as well, which we'd really encourage you all to respond to as well, so we can get a sense of how you're all feeling about the year ahead as well. And that will be to the same box on the right-hand side, and we'll come back to that poll at the end. We also hope you've had the opportunity to visit our resources page, which includes some useful resources that will relate to the topics we talk about today. So please do dip into that during today's broadcast, or if you're then catching up on demand. But as I say, very much an audience-led event where we, those of our colleagues at King's Fund, find it really interesting to engage with your questions and understand the kind of key issues that are filling your minds as well. So I'm really delighted to be joined by my colleagues Andrew, Siva and Sonia, who will be hearing from shortly in terms of some brief opening remarks before we open the floor to the questions. But I thought I would just kick us off first before we hear from my three colleagues, really by reflecting on some bigger strategic shifts, because I quite often find in health and care at the moment, the scale of pressure and crisis that people are feeling working in the system and patients are feeling in terms of being able to engage with the system can mean we can think in quite short-term ways. We can be thinking about a few months ahead, 6 months ahead, maybe 12 months ahead. But I just wanted to reflect on maybe some slightly longer term shifts that we are seeing. And some of those are hopeful and some of those aren't, but it's important that we're honest with each other. So one of the shifts for me is around public and patient satisfaction with the NHS, where we are now seeing this being at an all-time low in terms of it being measured by the British Social Attitude Survey. And what's really important to say is it's not just overall the all-time low. When you look at individual services, we're seeing it be all-time low against everybody. And that's a really important issue for us to think, how can we take the public with us as we are trying to improve services? So patient and public satisfaction is shifting. We're also seeing real shifts in the workforce. People will be very well aware of low morale, strikes, industrial action, tensions and challenges around how we can best reform the workforce so it's fit for the future. So some real potential challenges in workforce. We're also, for the first time, we're a generation who will be less healthy than the generations that came before us. So if you look at how life expectancy has been stalling since 2010, that is really a significant shift after decade of improvement in our health status. So a real challenge. But if that's all not particularly hopeful, where might we be able to look to think about hope for the future for our health and care system? The first is, for me, is around the potential of life sciences, where we could genuinely see a shift in the kind of care we can provide, the potential to cure diseases and the potential to live with conditions much more ably. So life sciences being a huge potential for us. And then finally, having talked about our health status being different and life expectancy having stalled, what we're also seeing, though, is a much wider recognition that the social determinants of health, the wider determinants of health, are really important to health, and it's not just about healthcare. So I think we're seeing a strong sense of connecting to that agenda, and hopefully, as we'll talk about today, the potential with an election and new action after election, the potential for more action to be taken to really address the health inequality space. So they are my reflections on some of the challenges in terms of strategic shifts and some of the hopes. I think there may have been a couple of technical problems with getting the live stream going to begin with. So apologies if you joined me halfway through my opening preamble, but it means that you got the hopeful bit of the preamble rather than the slightly more challenging bit of the preamble. But just in case people did miss some of the key housekeeping before I hand over to my three colleagues for their opening remarks, please do pop any questions into the box on the right-hand side. This is absolutely an audience-led event where we're here to answer any of your questions. So please don't be shy. There's no such thing as a silly question. There's no such thing as a too difficult to answer question. We will try to address all of those. And there will be a poll during the session as well, which again you can answer through the right-hand box. But I think that's enough for me recapping on the housekeeping. So I'm now going to ask my colleagues to introduce themselves and provide some of their kind of opening food for thought before we get going with the questions. And I'm going to introduce Andrew first. Thank you.
Brilliant. Thank you, Sally. So my name's Andrew McCracken. I'm Interim Director of Communications here at the King's Fund. Sally, you started this by talking about us looking into our crystal ball. I'm not sure I need a crystal ball or anyone does for what I'm about to say, but that is, we are in an election year. We know that it's very likely to be 2024, almost certain. I'm currently 65% that it'll be autumn, 35% that it could still be May. And that is going to be a big part of the context for health and care in 2024. And not only do we have the general election, of course, we've got local elections in May. And one of the noticeable things that we've seen already in 2024 is the struggling finances of local authorities. I think an LGA survey recently found that it's 1 in 5 council leaders and chief execs worry that the council is going to effectively declare bankruptcy in the next year. So things are particularly tough there. So as well as a general election, there's also those local elections that are going to be a consequence for health and care in May. When it does come to the general election, the NHS, and it is the NHS specifically, is normally in the top 3 of the issues amongst the general public when pollsters ask them what is bothering them. Interestingly, it's normally not top at the moment. Top is economy or cost of living. But when it comes to the NHS, there are some things that are clearly going to be flashpoints when it comes to the election. One that we know is concerning political parties is this concern around NHS productivity. We also know that migration, immigration is a big issue for the political parties, and we know that the health and care sector relies on overseas workers coming to the UK. And of course, the obvious one is access to care. So waiting times, how people are able to get through the front door of the NHS is clearly going to be a big issue for the general election. But for all the focus that will be on the election and the campaign, when it comes to the sector, the really interesting bit comes after the election. Whatever party forms the next government, it's likely to be an election of change, and they're going to want to do things and do them differently after the election. And that's going to mean changes for the system, changes in the interaction between national leaders and those elected leaders, and that implementation period is where it's really going to be felt in the health and care statutory services. The final thing I'll say before we pass on to another colleague is that, of course, the election is interesting, but there are other things going on in national politics ahead of them. Potentially one of the most consequential is what we saw in the news yesterday, plans to bring in a phased ban on smoking. Genuinely has the potential to be a game changer in terms of health in this country. It's not a done deal, that legislation. We saw reports this morning that there are significant numbers of MPs who might rebel against it, but that is going to be a big story throughout this year. And the other one that hasn't had as much attention yet, but I think has the potential to be very interesting, is where the COVID-19 inquiry is up to. So Module 1 we've had. Module 2 was the one where we saw lots of big famous political speakers being quizzed by Hugo Keith and others in the inquiry. Module 3 is about the NHS, and that's coming up later this year. So there'll be the NHS staffing, infection control, all of that through the pandemic is going to be under the microscope. It might not grab the headlines in the same way as earlier modules, but it's going to be of interest to the sector and of consequence to the sector. They're the things on my mind into 2024.
Great, thank you very much, Andrew. Sonia, over to you.
Thank you, Sally. So Sonia Wallbank, Chief People Officer out in the system and Programme Director for the King's Fund. My emphasis this year is definitely on recovery. So recovery before we can start delivering some of those elements of the people plan. So absolutely recognising I'm currently working in a community provider where the demographics of our staff teams tends to be that little bit older, so people coming into the community setting post an acute career. I think staff wonderfully managed the demands of the pandemic and things that were being thrown at them, but not without personal impact. So how do they recover from that? How do they do their best to keep well and ensure a long career? I think there is a real question around people who are able to retire. So we've got nurses able to retire well at 55, and we want to keep and attract them into having a longer term career with us, potentially retire and returning. But what would be attractive in the NHS to enable people to actually want to do that? And if we don't kind of look and challenge some of the way in which we work, if we just keep piling that work on top of people, they are going to want to retire and run rather than retire and return. We're about to start a study looking at the longer term impact for community staff and GP staff in particular around what they need to enable them to recover from the pandemic. What's their health and well-being looking like? I think the other question for me is attraction. So if you remember when we were banging pots and pans during the pandemic, there was lots of excitement about potentially people joining the NHS where they may have not thought about that, and having three young girls who are all interested in potential careers with the NHS, it felt a really exciting time. And that's now gone away. And so what have we got? Who are we wanting to come and join us? How do we start to attract and really think about what does the organisation need to look like for young people want to be attracted into it? So I think lots of questions for us to ask ourselves in terms of how we structure the work in the future, but how do we keep people? How do we retain people? And then how do we continue to attract people into the service? Thanks, Sally.
Thank you very much, Sonia. Obviously, people are a core part of how we deliver health and care services, so really important that we keep reflecting on the challenge and opportunity there. And then Siva, over to you for the last opening reflections.
Thanks, Sally. Hi, everyone. My name's Siva Siva. I'm the Chief Analyst here at the Fund, work for Sally and the policy team. And thinking about the year ahead, I think there were three things I was particularly going to focus on. One is about the money, and it links to what Andrew was already saying. You know, we talk a lot about the funding of the health and care system. Is there enough money? Over the last 5 years, what we haven't talked about as much is the financial performance and how that money is being used. And I'll tell you what, the number of integrated care boards, the number of councils that are running into financial difficulty and levels of difficulty where, you know, it will clearly have an impact on the quality of services for patients and the public. I think we're reaching one of those points where financial performance of the health and care system rises right up the policy agenda and the political agenda. So that was one thing. The second thing is a sense of limbo. And again, it links to what Sonia and Andrew were saying. It feels like as a sort of planning situation, we've got industrial action. We don't know how much and for how long. We've got an election coming. I'm just struck by how many rooms I walk into in the NHS in particular, where people are saying, well, what does politician X think about collaboration? What does politician Y think about health inequalities? So I think there's a real risk that it's a year of inertia, a year of limbo, rather than a year of let's crack on and address some of the challenges facing the health and care system. And the third and final thing is, you know, again, Andrew mentioned it, the smoking ban. You know, I remember when I was a kid growing up seeing an advert by an actor called Yul Brynner talking about the cancer he had due to smoking, and it scared the bejesus out of me. But within our grip is potentially ending those sorts of deaths, or certainly reducing them. So I think that in 2024, when we look back, will be possibly the thing that has the biggest impact on the health of the nation for years to come. So those are my three, Sally.
Yeah, great. Thank you very much, Siva. And I think that point about the smoking ban is absolutely right. I worked for Patricia Hewitt when she was Secretary of State for Health when the original smoking ban was introduced. And you definitely had a sense when it was happening that this would be the thing that would be defining health in a way where we were doing lots of interesting policy about changing the structures of the NHS and trying to change incentives, but actual impact on health, you definitely felt that it was the smoking ban that was going to be the thing in 20 years' time you'd remember, and that's definitely been the case. So excellent. Right. So we're going to now come on to some questions. And as ever, I knew the audience wasn't going to let me down. And there's some crackers of questions here, which is really good. I'm going to start off by just asking some of the most popular ones, and then I'll kind of try and kind of make sure we jump around between some different topics. But Siva, the first question I'm going to come to you on, but I might chip in with an answer as well, because it's about the money. So the question from David Winskill, who's a patient voice advisor, is if 7 billion became available, would it be better spent on the NHS or on adult social care? Siva, over to you.
Wow, great question. So I think, you know, I'd give you the technocratic answer, which is when you look at the cost-benefit analysis. Yes, there's suggestions that you get better bang for your buck as a society by investing in things like prevention. So that's not quite adult social care, but not automatically saying more money is on the table, let's plug it through the NHS. So I think you need to work through, is prevention a better bet to improve the health of the nation? And on adult social care, again, I would say I've got to be honest, I think you're on pretty weak concrete evidence, but certainly the sense we've got from years of research is, given the parlous state of the adult social care system, yes, if I had more money on the table, that would be my first call for investment. And then the reason is not to prop up the NHS, it's because we've got an adult social care system that is been at a tipping point for about 3 to 4 years. The final thing I'd say, though, is that money shouldn't be used just as a stopgap. And so we return to needing £7 billion or £10 billion in 5 years. It buys you time to stabilise the system while you work on longer term fundamental reform of adult social care funding and finance.
Great. Thanks very much, Siva. Great answer. And I think I just add a couple of reflections. One would be to say, if the Chancellor called us up tomorrow and had 7 billion, I do think we'd struggle to spend it well in social care, that much money. So there's a bit about how quickly can you start to spend and make sure you're spending it effectively. So I probably, although I'm a big champion of the adult social care sector, would say maybe not all 7 billion going to adult social care, or have it done in a kind of a reasonable trajectory. The other thing to say when you're comparing spending on adult social care with spending on the NHS is, what do we mean by spending on the NHS? So if we mean spending in hospitals, or do we mean actually about how can we improve primary care, community care, to mean that people are supported to live in their communities and in their own homes more? So I'd be kind of thinking, if there was 7 billion on the table, for me that would be about adult social care and more at the community end of the NHS. It wouldn't necessarily be about trying to kind of keep activity in hospitals. So that would be my kind of a build from Siva's answer, I think it'd be fair to say. The next question, which is the second most popular question, is an anonymous one, but it's a great question. And Andrew, I think I'm going to come to you first and then maybe come to Siva for a follow-up. How do we get more funding for prevention? And I think this is where some of the kind of reality of the politics, reality of the money comes in. Everybody's talking about how important prevention is, but how do we make it happen, or how do we make the money talk on it?
It's a good question, and actually I should be careful that we don't slip too deep into the rights and wrongs of democracy, because I think that is relevant here. When we operate in a political system with 5-year election cycles, it is very easy for national leaders, and those are the purse strings, to be looking at what can I do, what can I fund that is going to make a difference ASAP in time for that next election. So we know that the political parties are not just thinking about election 2024, they are thinking about what can I do on day one that is going to make a difference, that people are going to notice, that they're going to feel when they go to the ballot box again in 5 years' time. And I think for some of those preventative measures, that can be a challenge. So there are the studies and there's evidence about interventions that can be taken and what they will, the benefits that they will bring, but trying to make that case in a way that speaks to politicians when there are a million other priorities is actually one of the big challenges. And what I would say is that, as I touched on earlier on, of the 3 issues that regularly top the polls of the sort of biggest issues for voters, there's economy and cost of living and NHS. And there's something in there about the economy, the parties pushing for economic growth, and the numbers of people, the record numbers of people who are economically inactive due to ill health. I think there's an argument to be made there, and probably more work to be done to gather evidence on that. But that would be one route to trying to influence a greater focus on prevention in this current climate.
Great, thanks, Andrew. Siva, is there more that you'd add on funding for prevention, and maybe pick up that sometimes Treasury can be seen to be the bad player in this space? So kind of what you see about their potential role.
Yeah, that's a good point. And I think the Treasury in some circles is portrayed as the bad person in this, though, the Treasury, the officials working in the Treasury would benefit from a preventative health care system as much as anyone. I'd say there are 2 things. One is there are definitely some policy and technocratic things you can look at over how you could boost the amount of resources going into prevention. People are talking about, could you ring fence funds and dedicate them for prevention? Could you look at where prevention budgets sit in the health and care system? So I think, we should always look at whether there's a better way of organizing how money reaches the, preventative services. But the second thing I'd say is, I've got to admit, I'm getting a little bit impatient with this debate, because it always feels like the debate is, when will we have enough money in the health and care system that we can now turn to prevention and start investing in it? And I would say, look, the reality check is in the next 5 years, there's not going to be enough money that you can say the system is stable, now let's focus on prevention. So I'm more taken with the 3 or 4 parts of the country that are saying, let's look at the existing amount of resources we have. And as system leaders, we are making a conscious choice to invest more in prevention in line with the Hewitt review from last year. And it's not come by our stuff. They're saying, we know this will have an impact on waiting times and in the short term, but this is what stewardship looks like. So I'd say, don't wait, argue for more money, look at the technocratic side, but just don't wait for it, crack on.
Great, thank you very much. Really helpful answer. I'm going to move on to a question where I think I'm going to come to Sonia and Siva as a double-handed answer. So the question again from an anonymous viewer is innovation, technology and AI the silver bullet for the NHS? Or does it all come down to happy staff? And Sonia, I suppose what that led me to think is, to what extent can we see technology as helping staff be able to do their jobs well and improving their well-being, as well as being the kind of things that can shift what we can potentially cure and can shift patient experience. So Sonia, maybe if you could start off with that thought about technology and staff and where it can be win-win.
So coming into a community provider who spun out as part of their model of delivering healthcare a little while ago, so they're an independent provider, there hasn't been the money to invest in lots of technological solutions. And I think it's really held the evolution back for those staff teams. So things like a kind of HR help desk that's automated, investments in ways of working that will just help them be more efficient and effective haven't happened. So I think we're absolutely looking at both of those things. So increasing the ability to have staff work on areas that only staff can do, only physical humans can do, versus that technological way of working, I actually think is really helpful for bringing great job satisfaction. I then also think it brings that sort of innovative mindset. So how might we be able to do this differently? Is there a better, cheaper, more effective way of delivering this so we can focus on the work that actually brings happiness, I think, into staff teams, perhaps rather than some of that low-level work that we can automate. So yes, I'd be absolutely nudging down that road of AI.
Thanks, Sonia. Siva.
Thanks, Sally, and I'd agree with what Sonia said. I'd say a few things very quickly. One is, I'm really worried about the tenor of some of the debates we have, and this wasn't from the question, but the debate we have about technology and AI in particular in healthcare, because it feels like people are dividing into camps. One camp is, we really need to take this seriously, and that's going to be the thing that will transform healthcare. And the other camp is, it's all being overplayed. We need to focus on the fundamentals of healthcare, not be seduced by technology. So one point is about, it feels like we have a really unhealthy nature of the debate, very different to the debate in other countries like the US and Singapore over technology and healthcare. So that's one point. The second point is, as Sonia said, AI can make staff happier. You talk to clinicians about the things that really cheese them off, and some of them are laborious note-taking that AI can help resolve. And there are ways in which technology really does make your life easier rather than just layering on one more thing to do. And the third and final thing, again, picking up on something Sonia said, the one thing I'd say is our model of technological improvement in healthcare in this country, certainly over the last 10 years, has been find places that are already doing quite well and invest in them to go even faster and further and hope everyone else catches up. And I think we've seen that it just doesn't happen. So I think one of the things we need to reset is how much support we're giving to other parts of the health and care system that are underutilizing technology rather than letting the pioneers fly even further away.
Right. Thanks very much to both of you. Really good answers to that question. The next question, we're slightly changing topic, and I'm going to come to you first, Andrew, if this is okay. So the question is that patient and public engagement and co-production are ever more important to get buy-in to services. So why is it such a struggle to get this right, and what can be done about it? So Andrew, over to you with not a very easy question. Apologies.
No, it's not an easy question, and it's but an important one. And I think one of the things that's on my mind, I might actually draw together this question and the previous one, but is about Headspace. And it is an extremely busy job if you are working in a provider of NHS care, social care, or any other sort of role within the system at the moment. whether it comes to the adoption of new tech, using that example, you do need some headspace and some time. Even if you've got even if there's the potential for that solution to save you a lot of time, you need some headspace and some time within your workforce to be able to implement that. And I worry that the same is true when it comes to engagement with communities. That sometimes that stuff is, and you know, it's not always easy. It's hard. You're dealing with knotty issues and conflicting views and lots of different data points, and it's not, you know, you need to take time with that sort of stuff in a system where people don't feel like they've got much time. But it perhaps goes back to something Siva was saying when it came to public health spending, that there isn't going to be a sort of, you know, we're not going to overnight after an election find that there's a whole load of spare capacity and spare resource within the system. So I think it's about a mindset shift to recognizing that doing that sort of work will come up with the better solutions, but it's about being able to carve out that space and time to do it, is my opinion.
Yeah, great. I think that's absolutely right, Andrew. And a couple of thoughts I'd add to that is I think there is huge potential with genuine integrated working through ICSs where you can bring the broader expertise that local government have about how do you engage with communities and bring that into the NHS, who I think would be the first to admit they've not tended to be as good at this. So I think there's something about learning from different partners, learning from the voluntary sector as well, who have really deep understanding with the communities they work with. I think the second thing to reflect is that some of this does feel to me like a cultural issue where I think sometimes the NHS can demonstrate being a bit too scared to ask the public. So they then end up asking the public very defined questions about reconfigurations rather than a broader questions about what's important to individuals. And I think that fear comes from, but what if the community tells me loads of things that I can't then do? Have I just set myself up to disappoint them and to fail in that way? But actually, there's lots of experience in local government with engaging with communities where by entering into a dialogue with communities and people to understand what they want, what's important to them, what assets are available elsewhere in the community, you can actually find creative ways to meet people's needs. And it doesn't just become a demanding list of I want all of these things, and if you don't give me all of them, I'll be disappointed. So I think there is something about learning it doesn't have to be as scary as I think sometimes we think it can be. So a really, really important question, and I will just flag a piece of work that will be coming out from the King's Fund later this year, where we've been working with the Grenfell community to understand how they, as a community, worked with local health and care services to make sure those services really reflected the needs of that community at that point in time and since then. So we'll be sharing what we expect to be a really powerful report about the experience of that community and what wider health and care system can learn about how you genuinely work alongside communities rather than doing it in a tokenistic way. So do keep an eye out for that one. So thank you for that question. And that came from an anonymous. We've got lots of people being very shy today with their questions, but they are great questions nonetheless. The next question, Sonia, I'm going to come to you on. And the question is, stress and anxiety is becoming normalised in the NHS. The question says especially among nurses, but I think it's among a lot of different professional groups. How can we address this as pressures remain in the system due to vacancies?
Yeah, huge question. And the reality of coming to work for the health service is that it is not absent of stress, anxiety and burnout. So I think there's a couple of things for me around recognising the pressure that is placed on you doing a particular role and ensuring that we are educating the staff groups who are coming into provider services that this is what the job is about. And therefore, how do I take the stress that I'm going to experience at work and do something in order to reduce the impact on me? So things like supervisory space, a good relationship with your line manager, fabulous teams, and the way that you work together, we all know reduces stress. One of the other things that the NHS has maintained itself, I think, on for years is the fact that you will have compassion and satisfaction. So you gain a great deal of pleasure from the caring role that you provide across health and care, and therefore that can mitigate the impact of stress and burnout on you. I guess we've reached a tipping point, and I think post-pandemic, people are not necessarily feeling the pleasure around the role that they do. So workplaces and employers really thinking about how do we build that relationship back between the staff who work here and the patients or service users that we're providing care for. I don't think there is an easy answer, but I absolutely think it's a collective one. It is difficult work. I don't think we should shy away from that, but there absolutely are fundamental ways that we can overcome this.
Great, thanks very much, Sonia. It's a really helpful response to what is a very, very significant question in terms of how we can make progress on the disturbing levels of stress. I'm going to come to sort of combine a few different questions, which I think are all hitting at the same kind of issue. So we've had some questions saying, should the NHS just be taken out of, have no political oversight and interference and direction? We've had some questions saying, should we just move to a private, is it inevitable we'll be moving to a privatised model? Should we start charging for use of healthcare, like use of GPs, etc.? This is a question that we quite often get asked from the King's Fund, and broadly I summarise it as a feeling the NHS is broken, something radical must be done. That therefore must mean let's get rid of the NHS and have a different form of healthcare model. I was going to come to Andrew and Siva for their reflections on, as I say, a bit of a combined question about, in effect, the structure. Is the NHS as a tax funded free at the point of use? Is that the right model, or should we shift to something else? So, Andrew, I might come to you first, and then Siva, potentially to bring in some of the international comparisons and experience as well.
Yeah, so on the involvement of politics in the health service. So I guess, how many years ago was it now? Just over a decade ago when NHS England was created, that was the thought process behind that was in part to try and depoliticize some of the decision making around the NHS in particular, to spin that out of the Department of Health as was, and have this separate body, one of many different national bodies. I think for me, I think you're never going to fully depoliticize the NHS, and I also don't think you want to. Like, a huge amount of taxpayer money goes on that service, and it is, that word again, democracy. I think it's pretty fundamental to our political system that when people are, the government is gathering up those taxes and choosing how to spend them, that they should have some say in how they are being spent. Now, there is a question about the level of granularity that politicians go to and where is the best expertise for making certain decisions, but I don't think you're ever going to fully depoliticize the NHS, and actually, in my opinion, nor would you want to. In terms of the model, what I would say is, Sally spoke earlier about levels of satisfaction with the NHS being at an all-time low. That's some work that ourselves and the Nuffield Trust do every year, and we found that it was down at 29% satisfaction in the most recent survey. In that same survey, though, we asked people's support for the founding principles of the NHS, and they are very, very high. They are rock solid. So despite those low levels of satisfaction, belief in a system that is taxpayer funded, universally available and free at the point of use is around the 70 or 80% mark of support for each one of those three. So despite the fact that we do occasionally see these calls for a complete overhaul to some alternative, it's not where the public seem to be. Yeah, I'll pause there if Siva wants to add, and I could chip in on other models if we've got time.
Lovely, great, thank you. So it's not where the public want us to be, but Siva, I wonder if you could then also explain it's not really where the international evidence would suggest we need to be as well. So over to you.
Yeah, thanks, Sally. Thanks, Andrew. I'd say, again, two or three things. One is, I think we've got to take it really seriously when people are questioning the model of the NHS, and never dismiss it. I think it is really meaningful when people feel so much anxiety that they're questioning, is this the right model of healthcare? So that's one thing. The second thing is, as you said, Sally, when you look at other healthcare systems, if there was a different type of funding or organizing principle that we could adopt, whether it's social health insurance or greater use of user charges, I'd be all for it. But the evidence is that broadly, no one health system systematically outperforms another. And my goodness, it would take so much time and money to transition from one system to another. You're talking about changing legislation, changing everything from how pensions work. So I'd say only do that if you're sure that the other side is worth it. And I don't think the evidence says that. The other thing is, our model did work. 15 years ago, we weren't having debates over whether the founding principles of the NHS should apply because waiting times were being met, financial performance was broadly good. That was all within the existing model. So there's nothing fundamentally broken, even if the context has changed. The final thing I'd say, though, is we shouldn't sleepwalk into a different type of healthcare system. There are now some procedures where they're more prevalent, they're more done in the private sector, the independent sector, than they are in the NHS. That is not by design. That is not by intent. That is a reflection of the pressure public health services are under. So I'd say let's be purposeful about what role we want the independent sector to play in healthcare in this country and support that agenda rather than sleepwalking into something very different to what was intended.
Great, thanks, Siva. And for people who are interested in this question a bit more, we published a report last year that was looking at the radical alternatives, or the so-called radical alternatives to the NHS, to really start to understand what are they set up to try and achieve and deliver, and would they answer the challenges and issues that we have in the NHS in England at the moment. So please do take a look at that if you're interested. On a kind of similar theme, Siva, I'm going to come to you on this one. We've had a question about some people are now, because of the length of waits in the NHS, are now moving to fund their own private treatment or have more insurance. Is that something we should be worried about? What trends are we seeing, and what might that suggest for us in terms of long-term support for the NHS viability? Are we going to have a two-tier model, etc.?
Yeah, wow, very good, big question. I think some of the trends are quite clear. A growth in particularly self-pay, so not people taking out private health insurance, but on as you need a particular procedure, you pay out of pocket for that procedure. Again, the data isn't hugely consistent, but some worrying trends in how many people are using things like GoFundMe campaigns for routine care, and also people who are in lower income groups also self-paying for care. So should we be worried or not? I think we should be worried when it becomes clear, as it's becoming increasingly clear, that this is happening not by choice, but by necessity, where these are not procedures that are optional. You're not talking about cosmetic procedures, you're talking about life improving or life enhancing, or in some cases, life saving treatment. And B, where it's being paid for by people who don't necessarily have the assets or means to do so without entering penury. The fundamentals of our healthcare system are you get a comprehensive range of services, regardless of your ability to pay. That's being heavily tested at the moment. And yes, I think that is something that policymakers, politicians, and people like us are worried about.
Great. Thank you very much, Siva. I'm going to briefly take a pause from all the questions that are coming in, just to see if there's any kind of topics that our panelists are surprised about at the moment that we haven't had any questions or any discussions about. And it may well be that there is a question out on the screen, because we've got lots of them, but just, are there particular topics that you think we should pause on and have a brief conversation about? So I'll see if any of my panelists put up a hand, I'll come to you. If not, we can carry on cracking through. Siva, excellent. Thank you.
Industrial action. I mean, it has come up in questions about stress, but I'm surprised that we haven't been asked more about industrial action in the NHS. And maybe there are questions, but the other thing is just a reflection of how little it seems talked about. It's moved from page 1 to page 4 or 5 in some national newspapers, which, back to one of Sonia's points, we're at risk of normalizing something deeply, deeply unusual.
Yeah, that's a very good point, Siva. And clearly we're at a stage of quite a lot of uncertainty about what might happen next with industrial action. But it does seem like it's going to continue to be an issue for the service for the next, unfortunately, probably for most of the year. So a real challenge for individuals working in the system and those trying to access care. Yeah, okay. And Andrew.
Well, and just to say on that, I think it's going to be interesting when we see the NHS staff survey, which usually comes out in March each year. So we've had, 12 months ago, some of us were sat at a very similar event to this, talking about industrial action, and it was new then. And we are at risk of it being normalised now. And I wonder if what we're going to see in those survey results. The other thing is the industrial action is ongoing, but we hope that solutions will be found. Even after the point that there's a resolution and agreement that is palatable to members of unions, what's the long-term impact here? What is happening in terms of relations between professional groups? And I think one of the things that I found worrying with the most recent industrial action. We're starting to see some of the stories in the papers that wasn't just about union v government, but it was upset and dispute and spats between different professional groups within. The example I'm thinking of were hospital trusts around the derogations and some of the data that was available. So as well as the industrial action itself, looking beyond that to think what is the potential scarring effect of this.
Yeah, I think that's a very important point. That how do you, once we're through this particular phase, how do you reset the relationships to mean that there's really effective teaming right across different professional groups, because we know that's so important to delivering good quality services. So great, thank you. So I'm gonna dip back into some of these questions. We had originally thought we might do some quick fire, but there's no way these questions are quick fire. Our audience is asking us questions which are a bit too deep and meaningful from for that. So let me just see what we think the next question should be. So Siva, this we've had a question asking, sorry, I've just lost it because too many more have come in. The question was asking, given the delays to care that were caused by COVID, do we think they're reversible, those delays, or has there been a permanent scarring cause that just means the level of performance will now be different to what we were used to? So yes, thank you for my team for bringing the question up. So are the issues in NHS delays and wait times that were created by the COVID pandemic reversible, or have they left some permanent damage? So Siva, I think
Gosh.
you
Do you know what? This is a rare moment of me being glasses half full. Is that the optimist one, glasses half full? Because I think they are reversible. I mean, it's not going to be easy, and I don't say it lightly because it will take a heck of a lot of graft and time. But I think one of the important things to remember is, say, waits of over a year for routine planned consultant-led treatment. They used to be worse. You know, there were points in the 90s where the data were even worse, if you can believe it, than they were during the height of COVID. So I would say there is still that muscle memory in this healthcare system, and from what we've seen in other healthcare systems, that you can absolutely get waiting times back to the level they should be at, where targets are being met. I think the problem we make is we're too ambitious over how quickly that can be done and how much resource it takes. You know, previous work we've done suggests you're looking at, unfortunately, 8 to 10 years rather than 3 to 4 years.
Andrew, you wanted to come in.
Well, it was only just to flag, we did some work here at the King's Fund, the very back end of 2022, looking at how to bring down waiting times, and was specifically looking at the elective backlog, and there was a political dimension to it. So one of the findings, looking back at previous attempts to bring down large waits, was that having very clear political focus was part of it. So looking in particular at the 2000s, where we did have large waiting lists that did then come down by the end of that first decade of the century. One aspect of that was that there was a real focus coming from number 10, Tony Blair specifically, he was the Prime Minister at the time, having regular, I think it was weekly meetings and organising targets and policies around that aim of bringing down those waiting times. So there's something about political focus as well as focus within the service to get things back on track.
Great, thank you, Andrew. That's really helpful. One set of questions I wanted to ask, again, slightly shifting topics, trying to make sure we kind of cover the broad areas that our audience are asking us about. And Sonia, I'm going to come to you first on this one, because you've got experience of actually kind of trying to roll up the sleeves and do this. We've got a number of questions about integrated care systems, kind of, are they really integrating? Do they really understand the kind of breadth of issues? Are they really going to be able to think about integration with social care and to think about pathways outside of hospital? So I think there's just quite a few questions about, are ICSs living up to their potential? Do they really kind of get it? So as I say, Sonia, you've been kind of, you're at the front end trying to make this stuff happen. So I'd be interested in your perspective on that.
Yeah, I think you've got to believe in the hope that we can integrate and integrate well. And there are a few services, thinking of in the north particularly, some fantastic examples of end-to-end services really working hard to pull budgets, to really thinking about their staffing models, being a bit more creative about who they're attracting and how they're working together, to absolutely give us hope that this is a model that may work well in the future. I think those artificial barriers between care and between health are probably something for us to pay attention to in terms of really focusing on stepping those down. And then, of course, professional boundaries. So I've always done this work. Why do you now want to do this work? I think we need to really be careful about how we work together to kind of stand down some of that professional space where we don't need to be fighting about who does the work. Somebody's got to be able to deliver that work. I feel really hopeful, though. Some of the brilliant models that I've seen across those ICBs starting to come to life, a little bit of green shoot showing, should absolutely give us the hope that this is the way of working in the future. And financially, I don't think we can afford not to be working across systems together rather than as individual providers. So yeah, absolutely behind it.
Thank you, Sonia. Just want to check in with Siva or Andrew if they wanted to add anything from a kind of policy perspective from Sonia's experience of doing it. Andrew, you look like you're about to jump in.
It's only to say, I think if you ask most people in the sector, they would say, please God, don't do another top-down reorganisation of the NHS to any of the parties. And thankfully, none of them are saying that they will. We know that the current government are committed to ICSs, and we know that the Labour Party, likewise, although they might want to tweak how they work, are committed to the structures.
And Siva.
Thanks, Sally. And I was going to say it is absolutely legitimate to ask two questions. The first question is for people who want to get rid of ICSs, integrated care systems. What's your alternative? Tell me a better way for improving the health and well-being of people in this country and reducing fragmented care. I would genuinely like to hear it, but one is tell me alternative. And the second is, again, it is perfectly legitimate to say to integrated care systems, give me the examples of where either you've started something that wouldn't have been there before, like a focus on health inequalities, or you've taken a flame and spread it through a patch in a way that wouldn't have happened before. I think those are reasonable questions, and the answers are starting to emerge. But I think ICSs have a challenge over the next year of proving their worth.
Thank you very much. I'm going to now slightly take Chair's prerogative because there's quite a few questions about social care. So I think I'm going to ask the questions and answer them as well, but very happy for my panelists to chip in as well. So as I say, we've had quite a few questions, some of them around why is social care not seen to be as important as the NHS? Why is social care always in the too difficult to do politically box? What prospect is there of a national care service? So I'll try, without giving my 4-hour lecture on social care, try and kind of touch on those issues. So why isn't social care seen as being as important as the NHS? I think it's for a few reasons. One is actually the NHS tends to be, all of us have connection to the NHS at some point in our lives. We would have gone to the GP, through maternal care, through later life care. So we're very used to the NHS. We would have gone to A&E. Quite often people don't have much interaction until the social care system, with the social care system, until they have a kind of crisis. A lot of what happens with social care happens, if you like, in people's homes. It's quite private, it's quite hidden, whereas we're used again to the NHS being about big buildings, about hospitals, about ambulances. So when things start to go wrong, you start to see queues of ambulances outside a hospital. It's very visible, whereas what you don't see as much is what's happening to the individual who's in their own home and not getting the level of support they need, or their family carer is breaking down because they don't have enough support. So I think it's quite an invisible service as well. And that invisibility in comparison to the NHS means that, to just put it bluntly, MPs get a lot of letters from their constituents about the NHS. Historically, they haven't had the same level of concern raised by their constituents, really, until it's people who, as I say, are at that crisis point. So sometimes the relative political priority does reflect what the politicians think they hear from their constituencies. Now, obviously, the role of a politician isn't just to do what their constituents ask them to do, it's also to be thinking about the challenges and opportunities as a country we have and where we need to make improvements. So this is where you do need bravery. Why has it been in the too difficult box? And I think it's really important we're clear which bits are in the too difficult box. So it's quite often it's the question of how should we share the cost of social care that ends up being the politically toxic debate, and certainly the last few elections have demonstrated that. But there are a whole set of questions around social care about how do you ensure recruitment and retention of the workforce you need now and in the future, how you drive quality, how do you really have personalised care, what's the best model of care for different groups who are supported by social care. So I think it's important to reflect that you can reform social care without it just being a question about how do you pay for it. And fundamentally, that then is starting to get into people's inheritance, people's taxes, which does, get politically difficult. So all a real challenge. All of that said, what do we think the prospects are for social care coming into the election? The Conservatives have said that they will implement the catastrophic cost cap in October 2025. To be honest, we'll find out quite soon if they mean that, because they'll have to start funding implementation activity. So by the spring, if we're not serious with implementation, we can fear that we're going to see another repeat of the Conservatives delaying and backing away from reform. And they have a white paper on social care reform more generally. Labour have committed to developing a national care service, and some organisations have done some work for Labour about defining what that might be. That is likely to be a big kind of 10-15-year reform programme to define what is a national care service and move slowly but surely towards that. So not going to be something where it's a particular kind of structural change overnight and we fixed it. It will be a slow and steady change. And as Siva talked about earlier, when we had that mythical 7 billion, some of that will be around how do you stabilise and maintain the current system whilst then reforming and changing. So in 10 years, you have a very different system that's better meeting the needs of people who need to draw on social care to live their lives in their communities. So that's my very quick take on social care. I should check in with my panelists as to whether they want to add anything. Andrew's going to. Great.
Well, no, I'm trying to be optimistic, but I'm going to start by being pessimistic. So we've spoken earlier on about NHS satisfaction being down at 29%. Satisfaction in the same survey with social care is 14%. Like, it really is very low. My glass half full bit is that for as long as I've been working in the sector, I do feel like social care and the issues in the sector and people's challenges accessing care and experience of it are a little bit more prominent and a little bit more on the public's radar. And I think a lot of that is to do with the pandemic. I think it was very visible, some of the things that were going wrong in terms of whether there was or wasn't a protective ring around that sector. And that translates into mainstream dramas. I forget what it was called. There was the Jodie Comer and Stephen Graham thing. Help, I think it was called. Like it did cross over. I think there is more awareness now. We could do with more again.
Right. So Sonny, was that a hand up?
It was.
Yes.
Quick hand. It's really interesting because I think there's something we see as NHS over here, social care over here. We don't see it as a continuity of that service. But if you talk to any of the district nursing teams, any of those community teams who are already working really closely with social care, I think we've got to look at it in a more intelligent way that says there's no way that district nursing, community nursing can do its job well if it hasn't got an appropriately funded and active social care offer coming through. I think too often we look at it just down that one lens and say it's a problem that needs to be resolved over here, rather than those two systems being able to work together really well.
Yeah, I think that's absolutely right, Sonia. Thank you. We're coming to the final 5 minutes or so. So what I was wanting to do was kind of come to the speakers for some of your final reflections, but doing that in the context of what we have seen from our the poll we did with our audience. So if my team can just pop up the word cloud, and just to see, let's see the words that are resonating with people here today. And I suppose I'd like to understand, do those words resonate with you, or do you feel more positive, less positive, more hopeful? And I think in particular, what struck me was some of the words are much less positive than 12 months ago, which is a real surprise. And sorry, I'm just going to have to speak to my team. My team, can you pop it up on the Slido screen for me, please? Because I can't see what's just been sent. But a real sense of much, sorry about that, audience, much less positive. And I wonder if this is the tiredness after the kind of feeling beyond COVID, we're still carrying on battling the consequences of industrial action. But some of the words here are worried, concerned, broken, overwhelmed, under-resourced. There are some positive words like hopeful, but a lot of this is much more negative than we would be used to hearing, even in some challenging times. So I suppose in the last kind of few minutes, just as I say, coming to each of you as panelists to think, what do you take from the words that our audience are saying? I mean, there are people talking about opportunity, as I say, hopeful opportunity, but a real sense of quite a lot of pressure, quite a lot of stress, quite a lot of concern and anxiety. Despair being one of the words that's just popped up. So I think I might come to Sonia first, then Andrew, and then finish with Siva in terms of reflections, if that's okay.
So there's something for me, Sally, about normalising the unusual. So post-pandemic, not being able to give people an appropriate time to recover feels that that's a missed opportunity for us. Strikes, stress, strain, all of those negative things I think I'm picking up from the words there. There's got to be something about building hope, looking at places where actually the work is coming together. People do feel that they're getting traction and doing things well, feels really important rather than just reinventing new ways of working. And then connectivity. So how do we as one organisation deliver what we want to be delivering for the future? I don't think we can, but how might we connect as a system? How might we connect as a bigger strength of organisation? But absolutely reflecting hope, optimism, ways of working back into the system absolutely feels the work the health service has got to be able to move into.
Okay, thank you, Sonia. Andrew.
Remarkably similar, to be honest. I think if I think about the here and now, clearly things aren't good. You know, when you've got, I think the stat is 6 in 10 of the most deprived people in this country say that the cost of living crisis is impacting their health. Like, that is not a situation we want to be in. And it's, you know, it's not just the breadth of poverty we've heard from other organisations recently, it's the depth of poverty as well, and that has an impact on people's health. Things are clearly very hard for the people of this country. That includes their health, and it's difficult working in a system trying to support those people. I do, though, have that hope when I look forward. And I know not everyone will feel this when it comes to an election, because there'll be lots of popular claims flying around and commitments that might not really get to the root cause. But I think things are so bad, there's a recognition it's got to change in some way, shape or form. And so whatever the outcome of this election is, it is going to in some way be a change election. And yes, it won't solve absolutely everything, but I genuinely feel hopeful about that, because people are looking to do things differently rather than just stick with the status quo.
Great, thank you, Andrew. And then Siva, you were glass half full earlier. Let's see if you're half full, half empty, or not quite decided.
Yeah, I don't know. Like you, Sally, I've been doing this sort of event 5 or 6 years. I can't remember seeing a word count that looked that bad. So what did I take from it? That people are responding who are tired, who are angry, and feel like the system isn't working for them, where it either feels too complex or it's not delivering for them. So that's one thing. And I think we need to accept that, and I'm not going to try and explain it away. If your experience is crap and you're delivering services or receiving services, I think we need to accept that. How I motivate myself is, we had a meeting between clinicians from organizations that are trying to collaborate. 3 hours of frustration, really difficult, really knotty stuff, lots of power dynamic, all of that. And then in the coffee break, one of the people, I was just asking, how do you keep going? And he was saying, oh, we've just rolled out this scheme where medicines get to patients so much quicker, so they don't spend as much time waiting for discharge. Completely revolutionized satisfaction in the pharmacy profession and patient care. I thought that, I know it's small, but that's what I'm going to hold on to.
Great. Thank you very much, Siva. I think that those kind of moments of hope and potential are a good point for us to end. So at this point, I want to say thank you to my colleagues, Sonia, Andrew and Siva, for joining me today and for taking all the questions I was peppering you with in good spirits. Thank you to you, our audience, for, as ever, asking us such good questions on such a breadth of issue. I mean, we could do a 24-hour event based on the questions you've all submitted, so really helpful. If you're keen to follow from today's session to understand more about the health and care system, some of its challenges and its opportunities, you can find out more by clicking on the resources page, which is off to the left of this video. We've got a number of upcoming events where you might want to join us, including our Leadership and Workforce Summit in March and our Health Inequalities Conference in May. So that's what's coming for us in the future. We'd really love to hear what you thought about today's event. And again, apologies for the technical hiccup right at the start. You just missed me blathering on. You didn't miss the panelists. So hopefully it hasn't impacted your experience of today too much. But please do fill in the feedback survey, which is on the left-hand side, because we really appreciate your feedback so we can continue to improve our events and make sure they deliver what you want. If you missed anything during today, or if you want to catch up or you want to share with colleagues, you can watch this event on catch up or on demand until the 27th of February. So you've got a chance to be able to dip back into this if you need to. And then finally, just to say thank you very much for joining us today. We hope very much to see you at another King's Fund event in the near future. But thank you and goodbye. Take care.